Assalamualaikum and a very good morning to everybody. Hi, my name is Dr. Zahra Tawil. I'm as representative of Weekend with Iapmd. Would like to thank you for joining us this morning. Can everybody hear me? You can type on chat. Okay, we'll start this morning with the introduction of our speaker, Dr. Faiziah Abdul Rahman. She'll be talking about dilemma in thyroid diagnosis, most common referral. Okay, Dr. Faiziah Abdul Rahman is a senior medical lecturer and consultant pathologist at the School of Medical Sciences, University Science Malaysia, Kelantan, Malaysia. She graduated from University Science Malaysia in 2002 and received her anatomic pathology specialty training from the same university in 2011. Dr. Wan has a special interest in breast and endocrine pathology. She had undergone subspecialty training on the breast and endocrine pathology from University of Griffith, Queensland, Australia, attended a diagnostic histopathology breast disease course under Imperial College of London. Her research interests are on breast cancer, thyroid pathology, and colorectal cancer. She has presented, I think everybody knows, in many national meetings and has published in several peer-reviewed journals. Dr. Wan, are you ready? Can I give the floor to you?
Yes, Alhamdulillah. Thank you. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And good morning to everyone. All right, thank you to Dr. Zara for very nice also thank you to the organizing committee to Iapmd, and especially for Dr. Zara lah, the chair for this session, and for this great initiative to have a weekend with Iapmd. I think this is a very good idea. And as you all know that this is my second time to be in this slot, and my first time I give on breast pathology. All right. And today I would like to give on the about something about thyroid pathology. Okay. Thank you everyone for spending your time to be with us today. I hope everyone can get benefit from the sharing of today. Okay. Now I would like to share my slide. Can everyone see the screen? All right. Okay. So the topic today is the dilemma in thyroid diagnosis at the most common referral. All right. Before that, I like the concept introduced by Dr. Zara for this weekend with Iapmd. So make sure everyone you have a cup of coffee beside of you, or maybe you can have uh, croissant or whatever breakfast that you prepare today, so that we can have a relaxed sharing session for this morning. All right. Okay. The concept is the what we call the relaxed environment talk, knowledge sharing, which about 1 hour, about 1 hour with us. All right. The main is just to share, to share with everyone the experience. All right. Just to educate our, especially the new pathologies. Okay. To make them confident in give a diagnosis, to update the knowledge, and it's just a happy sharing. I'm not a perfect in this topic, but I just love to share. All right, and feel free to interrupt me if you have any question. All right. Okay, what is actually the most dilemma in thyroid diagnosis? I made some survey among us, and based on the referral that I received, and I decide to give this topic for today, which is I will cover about cover about the follicular lesion of the thyroid. All right. I think this is the most dilemma based on the high number of cases sent for the expert opinion. Okay. Um, I divide into two groups, which is the follicular lesion of the thyroid, which is mainly the uh, encapsulated lesion of the thyroid. Well, it's encapsulated. Okay, I divide into two. Okay, first group is to differentiate between the adenomatous nodule and follicular adenoma and also follicular carcinoma. Okay, that first group. And the second group is to differentiate between the follicular variant PTC, especially the encapsulated follicular variant PTC versus the NIFTP, all right, or follicular tumor of uncertain malignant potential, all right, or well-differentiated tumor of uncertain malignant potential. I received this case quite many cases. I got it because most of us not sure whether to give it to call it uncertain malignant potential or just to call it NIFTP, or even is it the follicular variant, encapsulated follicular variant PTC. So today I hope I will clarify these things. All right. Another thing that make the thyroid pathology become quite dilemma or difficult because we have no molecular study so far that can differentiate them with 100% sensitivity or specificity. Not even molecular study, but also the immunohistochemical stain. We don't have a very good IHC for the thyroid. All right, so far. Okay, so before I'm going to the algorithm on how to differentiate each category, I would like to give a brief about each category. All right, and remember that I will just highlight the important points for that. Maybe you came across that you have read many times about that, but maybe you're not aware that might be a very good clue for you when you are dealing with the case. Okay, first we go about the adenomatous nodule. It is very common and important, but it's very sometimes very causing us become dilemma whether it is really adenomatous nodule or follicular adenoma or more than that. All right. Remember, the pathology should know that the most difficult task in thyroid is to differentiate between the follicular adenoma and also the adenomatous nodule. All right. Another name is, we can also call it adenomatoid nodule, the same thing, adenomatous nodule, okay? And it is most part of the nodular hyperplasia or multinodular goiter, all right? And it is mostly complete encapsulation. Remember, although it is a part of the hyperplastic nodules, but adenomatous nodule, mostly complete encapsulation. That's why it make our life become difficult, all right? And it has distinct growth pattern from the surrounding. This is a compulsory, all right? The nodules must have a high cellularity with microfollicular or solid growth pattern with a scanty colloid inside, all right? And if it is multiple, not a single nodule, we can call it adenomatoid hyperplasia. All right. And another problem in adenomatous nodule, because it's common to have the secondary changes. Sometimes the changes is very extensive, okay? And you might misdiagnose it as something else. All right. Sometimes you have a very extensive fibrosis, calcification, all right? Hemorrhage, okay? Or sometimes you may have a reactive endothelial hyperplasia that resemble the hemangioma. Okay, and you may misdiagnose as the anaplastic thyroid carcinoma or angiosarcoma, in fact. All right, and remember that in adenomatous nodule, you may have the metaplastic changes like osseous or adipose metaplasia. All right. So when you have this kind of morphology, everyone know this is very simple and basic in the thyroid pathology. When you have multiple nodules with this with incomplete thin fibrocepta, with the follicles showing the macro or micro follicles with a variable amount of colloid, with just a little compression of the surrounding adjacent thyroid follicles outside the nodules with no distinct growth pattern surrounding. So you can call this nodular hyperplasia. Okay, nodular hyperplasia. This concept, and you should know this. Okay, and you must search for this at the surrounding of the adenomatous nodule. All right. But when you have a prominent encapsulated solid nodule like this, which is distinct from the surroundings, and the nodule looks very high in nuclear density with a blue nodule, in change in the color become blue nodule like this, and you may have sometimes you may have variable growth patterns. You may have a plassolid or normal follicles instead of the micro follicles, okay, with a little compression at the adjacent tissue. All right, so this you may call this adenomatous nodule. So you can see the difference between the adenomatous nodule and the nodular hyperplasia hyperplastic nodule just now. Okay, so meaning that in nodular hyperplasia or multinodular goiter, you can have various nodules with a different types, and you can call it a different adenomatous nodule, what I mentioned just now. And if you have something like this, it shows that my internet is unstable. I hope everyone can still hear me. All right. Um, if you have something like this, it is hyperplastic nodules. All right. And if you have a very extended follicles which contain a lot of colloid like this, you may call this the colloid nodule. All right. Okay. So what is the features uh, favoring hyperplasia over the adenoma? Okay. How to uh, differentiate. We know that this is hyperplastic, not adenoma. Okay, one of the features is when it is being one of the multiple nodules, the one prominent nodules with actually they have multiple nodules surrounding. All right, when there is only a partial encapsulation or absent. All right, but bear in mind the adenomatous nodule mostly complete. All right, when there is a variable growth pattern within a nodule, a variable growth pattern, you have micro follicles, normal follicles, and sometimes macro follicles. And remember, this is hyperplastic process. All right, it's different from the adenoma because adenoma is more on the neoplasm and it shows a clonality. All right. Um, and it is variable in cellularity, okay, and then it's similar histologic features with the adjacent tissue with abundant colloid, no or just a little compression of adjacent thyroid tissue. So this is a clue that you should search when you want to say that this is a hyperplastic nodules, not adenoma. All right. So what about adenoma, follicular adenoma? Uh, as everyone know that dispute happens in distinguishing with the adenomatous nodule. You should know that follicular adenoma is neoplasm, so it is a clonal origin. Okay, patient may have painless nodule with asymptomatic. When we call it asymptomatic, patient mostly having cold nodule without symptom like hyperfunctioning. But in a few cases, it may have a hyperfunctioning, like in the hyperfunctioning toxic All right. And remember, it must solitary. Most of the time, it is solitary. it's very extremely rare for them to have a multiple nodule. We must think of inherited genetic disease when we have a multiple follicular adenoma. Okay, most of the time it has a complete encapsulation with typically only thin capsule, not a thick one. Okay, but sometimes mostly thin, but sometimes just moderately thick, not very thick. Okay, and the pattern can be normal follicular, macro, or micro, solid or trabecular pattern. It common to have only single pattern, but sometimes mix at least two. Although it is mixed with two pattern, one area it shows this pattern, another area it shows this pattern. It not mixed up like hyperplasia, right? Okay, and the cells usually it shows cuboidal or polygonal shaped cells, but if it is hyperfunctioning, the cell may become very tall cells. Okay, but the problem is in follicular adenoma, their cellular morphology is they have a very variant of the cellular morphology. They may have a lipid-rich cells, the clear cells, the signet ring, sometimes a with a bizarre nuclei and a spindle-shaped cells. This is the problem. But remember, when you have a very well encapsulated nodule with a high density, with a with the similar morphology of the cells inside the nodules, whatever morphology, lipid rich cell, clear cell, whatever, but think of the follicular adenoma, all right? And again, the secondary changes also common, like just like in adenomatous nodule, where they have fibrosis, hyalinization, hemorrhage, edema, cystic degeneration, calcification. All that can happen also in follicular adenoma. And one of the immunohisto that can be helpful in follicular adenoma, you can do the Ki67, okay? Ki67, but not that helpful because still you cannot differentiate with the hyperplastic nodules, but you can differentiate it with the follicular carcinoma because in follicular adenoma, the Ki67 less than 5%, all right? And another immunohisto is also important because sometimes the follicular adenoma resembling like a parathyroid lesion, resembling of the another clear cell change like in from the kidney metastasis. That's why you need to confirm that this is from the thyroid. So you can do the thyroglobulin or TTF1. Okay, and also calcitonin to exclude the medullary, especially for lesion with the trabecular pattern. And if you have your center have galectin 3, HbME1 or CITED1, this is actually the panel in thyroid diagnosis to differentiate with the carcinoma, although it is not not very specific. That's why we need to do it in panel. We cannot rely on one single immunohisto for the thyroid. All right. So if you have like this quite moderately thick capsule like this with the compression of the adjacent thyroid follicles like this is can be a clue for you to say that this is a follicular adenoma when you have a complete uh, uh, encapsulated nodules with compression here. And but when you can see here the content of the nodule, it shows you a few follicular growth pattern, but it's very nicely here. This is an area of micro follicles, and here the normal follicles. All right, this is a mixed pattern. All right, but of course you need to careful search to exclude the follicular thyroid carcinoma, and also for search for the cells, follicular cells to exclude for the follicular variant PTC. All right. The problem is in follicular adenoma because it has a cellular variance of the follicular cells that made the follicular adenoma become challenging. This is example of the follicular adenoma variant. Here, this is a clear cells. clear cell follicular adenoma when you have the cells showing the clear cytoplasm, just like renal cell carcinoma. That's why you need to do the TTF1 or thyroglobulin to exclude the metastatic disease. All right, and sometimes you may have the cells. Okay, this is also the clear cells, cell with the clear cytoplasm. It may be due to the deposition of the thyroglobulin, because when the deposition of thyroglobulin also can cause us, can show a clear, can cause a clear in cytoplasm, or accumulation of the lipid or glycogen, or due to the mitochondria that is ballooning in the cell, follicular cells. All right, and sometimes you may have the signet ring cells, follicular adenoma like this. That's why you also can proceed with the immunohisto to exclude any metastasis, as you know that signet ring cells can be anywhere, can be anywhere. All right. And sometimes you may have the spindle cell follicular adenoma. Okay. Um, it looks like anaplastic with the spindle cell, but bear in mind that this is the encapsulated tumor, very complete encapsulated tumor. How can the anaplastic? Anaplastic, I think, tak sempat untuk nak well encapsulated, very invasive, right? So the clue, sometimes you need to search another area. You may find the thyroid follicular pattern. It's not only the spindle cells only, right? And sometimes you may have the lipoadenoma. This is also another one type of the follicular adenoma, where you can have the mature adipose tissue interspersed throughout the tumor cells within the nodule, right? And this is a various pattern. You may have the solid pattern of the follicular adenoma. Okay, this time you need to search, careful search for the PTC nuclear changes. Need to exclude for the solid variant of the PTC. Okay, and you may have the follicular adenoma with papillary hyperplasia like this, or hyperfunctioning or toxic adenoma with the clear cells or tall cells like this, or the follicular adenoma with bizarre nuclei. Okay, remember when you have the bizarre nuclei like this with a degenerated cells, actually larger cell, bizarre, hyperchromatic, but it is well encapsulated punya tumor. This is actually follicular adenoma, not anaplastic or what more than that. All right. Okay. Now, how about the follicular carcinoma? Okay. Um, this is also most of cases I found we have dilemma in this deciding whether follicular carcinoma or not, because of the capsular invasion not that clear. Okay. It is usually called on radionuclide, okay, single punya tumor, and with a complete capsule, usually very thick. The one of the clue for the carcinoma, the capsule is very thick, and most of the time it is calcified. Okay, calcified encapsulation with solid lesion inside the nodule, just similar to the follicular adenoma like appearance. And for the invasion, the type of the follicular carcinoma, you should know the three invasion type, with whether it is minimal, angio-invasive, or wide. Okay. And
Dr. Wan,
yes.
um, one of the participants, Dr. Nurhaliza, said the slide is not moving. Maybe we can stop sharing and share again. Balik semula.
Okay. So no, Zara also cannot see the movement of the slide, ke?
No, mine okay. Tapi
Oh yeah.
tapi sebab baru habis kan. Then we share balik je lah.
Alright. Okay. Kita share balik ya. Sekarang menampak ke? Ada nampak slide sharing ke? Okay, Zara, ada nampak ni ke? Movement of the slide?
Yes.
Alright, okay. Now we continue. For the follicular carcinoma, okay, of course, again, the immunomarker may be positive for CK19. If you have CK19, galectin-3 or HbME1, that's good, but it's maybe positive, especially for CK19. But it's still not, we cannot depend on immunomarker 100% in thyroid pathology. All right. Okay, this is the classification. I hope everyone use this classification for the follicular carcinoma, WHO 2017. Okay, it is divided into three: minimally invasive or encapsulated, angioinvasive or widely invasive. Minimal, minimally invasive when there is only the capsular invasion without vascular invasion, and only the capsular invasion. Encapsulated angioinvasive when there is a with vascular invasion, regardless of number of the angioinvasive, less than 3 ke 1 ke, 1 pun okay dah, meet a criteria asalkan that invasion is meet the criteria for the vascular invasion. Um, Tumor cells must adhere to the vessel walls, and the vessel must be within or beyond the capsules, not within the nodule, within the capsule or beyond. And it is not a lymphatic invasion. Okay, it must be vessels, not lymphatic. Okay, kalau lymphatic uh, uh, lebih kepada PTC lah. Alright. Okay. And widely invasive when there is extensive invasion of the thyroid and extrathyroidal soft tissue, often with extensive angioinvasion. Right. All right. Okay. When we talk about the capsular invasion, you need to know. Okay. Okay. You need to know what is the criteria of the capsular invasion. All right. Capsular invasion. You can see from this infographic, I think this is a very good infographic to show you what the criteria of the capsular invasion. The concept, so far, no consensus to define, but this is the most recommended one. Okay. The C, D, the one here, the C, when this is the tumor totally transgress the capsule, yes, this is the invasion. Or when the tumor actually they totally transgress, but there is another fibrous capsule forming. We call it like a cloth cover the tumor. This is also acceptable. Or when the tumor is outside the capsule or the capsule, we call it the satellite tumor, like in E here. Okay, and here when it's a mushroom shaped tumor with a total regression. All right, so this is the acceptable one. This is, we call it capsular invasion, not this one, not this one. This is just a sharp tumor buds that need a deeper section. All right, and the rest, this the bosellation like this, or just I mean the mushroom, but it's not yet transgressed like this, is not acceptable. Or any other tumor within the capsule, whether perpendicular or parallel to the capsule like this, all that not acceptable. Only when it is totally transgressed the capsule or the satellite or the mushroom that apa tu, beyond the capsule. All right, that is the capsular invasion. So what about the vascular invasion? Okay, the criteria of the vascular invasion: the penetration through the vessel wall and reaction to the vascular deposit, or thrombus formation. The key features here is the thrombus formation that cause the reaction to the endothelial cells. Right, it is not a free floating like this. No, this is not a vascular invasion. You need a deeper level. Maybe it is a tangential cut, or it is when it's just a tumor bulging or indent the vessel wall. It's not a vascular invasion. Or sometimes you may see the tumor at the central of the vessel like this, although it is endothelialized tumor floating, but you need another deeper level because it sometimes due to tangential cut like this, all right? Or this is similar to C, but it is juxtaposed to the vessel wall. You need to further cutting a further section as well. All right, this is not yet considered as vascular invasion, but eh, only consider when it is juxtaposed to the vessel wall like this and associated with a thrombus formation, because it the direction of the endothelial cells toward the tumor. Of course, when there is a foreign body, especially the tumor, the cancer going into the vessel, the endothelial cell may show something direction that cause the thrombus formation like this. All right. So this is an example of the uh, lymphovascular invasion when intravascular tumor attached to the vessel wall or associated with fibrin, a thrombi formation. Okay. This is the blue arrowhead showing the endothelial cells. Okay. And a black arrow showing the fibrin, a thrombus formation. This is example of direction of the vessels when and there is a tumor invasion into the vessels. If you see the tumor just um, uh, within the vessel, but everything relax, nothing react towards that. So something, maybe something wrong. That's why you need to recut to see the evidence of the real invasion to the blood vessels. Okay. All right. Okay, this is an example of the angioinvasive follicular thyroid carcinoma with the vascular infiltration and the thrombus plaque within the vessels. And this is an example of the minimally invasive follicular thyroid carcinoma when you have a capsular invasion that transgress the capsules like this. This is the capsules. This transgress beyond the capsule now, and it is the thing covering is not the real capsule, but something is cover when the tumor is going outside of the capsules. All right. So now I'll go to the second part of the lesion, the dilemma lesion, where the follicular variant of the PTC. The what we are talking here is the encapsulated variant of PTC, not the infiltrative variant of follicular variant PTC, because we are talking about the follicular thyroid, encapsulated follicular thyroid tumor that cause dilemma for us. All right. So as you all know that the follicular variant PTC, we divide into infiltrative and encapsulated. But for the encapsulated follicular variant PTC, it is encapsulated with invasion. Now it's no more encapsulated follicular variant PTC, but must have invasion. So the question here, is it encapsulated follicular variant PTC is still exists? Okay. Um, Okay, that's why when we want to say it is follicular variant PTC for the well-encapsulated tumor, we need to carefully search for the invasion to confirm that this is a follicular variant PTC with invasion. All right. So there is a three diagnostic criteria to diagnose follicular variant PTC. First, there must be no well-formed papillary architecture. Okay, no well-formed papillary architecture. You may have an abortive papillae, but not a well-formed papillary architecture. And the second must be exclusively follicular growth pattern. All right, which is usually more than 50% lah. You may have another pattern, but must less than 30%. Okay. Um, and it must have the PTC nuclear features, papillary thyroid carcinoma nuclear features. And another pattern you may have like solid, nested, trabecular, scattered, poorly formed papillae, or you may have, but must be in very small percentage. The follicular pattern must be more than 50%, right? So another key features that maybe is very helpful for you to diagnose follicular variant PTC. First, you look at the follicles. It's foraminal follicles, but actually the follicles is quite irregular, elongated follicles with irregularly shaped follicles. And the important things is inside the follicles, it contains colloid. And the colloid is not similar to the colloid in nodular hyperplasia be- because the colloid is a very dense eosinophilic color. It's just like a bubble gum colloid inside the follicles associated with a peripheral scalloping. This is all the important point that I would like to highlight here so that everyone can give idea to you in giving diagnosis. And try to search for abortive papillae because this is a quite a important clue for you when you have abortive papillae, meaning that you are dealing with a papillary thyroid carcinoma, which is not a really conventional but a follicular variant. Okay, for follicular variant, you cannot have a well-formed papillary architecture. Even a small area cannot. But abortive papillae, yes. What the meaning of abortive papillae? This is a papillary lesion without fibrovascular core, not a well-formed papillae. All right, and it has a lack polarity within the cells, and you may have the substantial or discrete area of fibrosis within the lesion, the tumor, and you may have multinucleated giant cell within the lumen. All right, and then for the papillary nuclear features, you do not expect for you to have a full blown of PTC nuclear changes like in conventional papillary thyroid carcinoma, but you need to consider when there is a nuclear enlargement, nuclear irregular nuclear contour, the clearing, yes, but grooving, although you need to search for that, but usually it less than the conventional PTC. The same thing with the pseudo inclusion, the intranuclear pseudo inclusion, it is lack in the follicular variant PTC. All right. Okay, this is example of the follicular variant PTC encapsulated one. You can see the well circumscribed tumor on in the gross findings, and for the microscopy, usually it is a thin encapsulated tumor or moderately thick capsules. But what you have here, there's a follicular growth pattern. All right. Okay, this is example of the follicular variant PTC when you have this kind of PTC nuclear changes here. It's more on irregular, elongated, irregular contour of the nuclear changes. Okay, without sometimes without very marked clearing. All right, but there's elongation of the nuclear with the grooving here and there. And important thing is the look at the colloid inside the follicles is it has a very dense eosinophilic dark staining cytoplasm with peripheral scalloping. All right, peripheral scalloping there. All right, okay. But just bear in mind, because sometimes follicular variant PTC, especially for the infiltrative type of follicular variant PTC, you may have the macro follicular variant with cystically dilated follicles with the diffuse minute neoplastic follicles, okay, scattered within the thyroid without any distinct nodule, or we call it sprinkling a sign. All right, that's why it's very important for us to search for the PTC nuclear changes in whatever cases that you have for the thyroid lesion. Okay, because need to exclude this one. PTC nuclear changes, we need to be very good knowledge about that. Must be fingertip in your fingertip. All right. Okay. Talking about the okay. Talking about okay. Um, talking about the immunohistochemical stain for the thyroid lesion, as usual, I say it is must be in panel. No one reliable immunostain. So in this case, if you have the HbME1, that's very good because among the all the panel, HbME1 is probably the best single marker to assist in differentiate between the follicular variant PTC and follicular adenoma or adenomatous nodule. Okay, but if you don't have, you can do the CK19 or galectin 3. All right. Okay. Now back to our question just now. Does encapsulated follicular variant PTC still exist or have changed to NIFTP? Okay. So what I want to tell you here, when you have the encapsulated tumor with PTC nuclear features, not this is a really PTC nuclear features without capsular avascular invasion. After you doing the thorough sampling and deeper level, you better consider NIFTP. When you don't have the capsular avascular invasion. All right. However, in some circumstances, you need to consider another features like a very marked or convincing PTC nuclear features. It's full-blown PTC nuclear features, or sometimes you have papillary formation. Even it is a very small area of well-formed papillary formation, or when you have a solid pattern, which is a quite increase in the one area of solid pattern, bear in mind you cannot say it is an FTP anymore, because there's a case reported they diagnosed as an FTP. Someone conteng saya punya slide. When you diagnose a papillary NIFTP, but suddenly patient got metastasis, and then they go back to the case. They found actually that case is we cannot call it NIFTP because there's an area of papillary formation. Okay, there's an area of papillary formation, well-formed papillary formation. Even there is a small area when you have a well-formed papillary formation, now it become conventional PTC. All right. And sometimes you may have a solid pattern. And bear in mind, if the solid pattern is quite increased, you need to exclude the solid variant of PTC. Okay, when you have solid pattern and you have the PTC nuclear changes, it may be the solid pattern, the solid variant of the PTC. So it's not considered NIFTP anymore. All right. And sometimes when you have a solid pattern, you need to search for the convoluted nuclei because sometimes it is poorly differentiated for thyroid carcinoma with a solid pattern. All right. So now we go to the tumor. When we talk about tumor of uncertain malignant potential, okay, we are talking about the follicular tumor of UMP, the uncertain malignant potential, the well-differentiated tumor of uncertain malignant potential, and as well as NIFTP, we can consider it is under uncertain malignant potential, although it is not really uncertainty. All right. So, what is actually what the uncertainties in these three cases? All right. It is because it, of course, it is must be encapsulated, well encapsulated, or well demarcated. Why we call it well demarcated? Because sometimes it don't have capsules, but the lesion is very well demarcated from the surrounding. So we call it well demarcated. So it is acceptable whether well encapsulated or well demarcated as long as it well circumscribed and well demarcated follicular pattern that pose diagnostic difficulties in terms of first, number one, because to determine whether there's a presence of capsular vascular invasion or not. Okay, and the second uncertainty because of the uncertain in their nuclear changes of PTC or not. All right, so that's why we have this category. Okay, for the follicular tumor of uncertain malignant potential, we are uncertain about number one. We are uncertain about the capsular or vascular invasion, but there is absence of the papillary thyroid carcinoma nuclear features. Remember that. Okay, for the if it suit to this case, so we can call it follicular tumor of uncertain malignant potential. All right. But for the well-differentiated tumor of certain malignant potential, it may be uncertain in both categories. Well, uncertain in capsular vascular invasion, also uncertain in the PTC nuclear features. But for the NIFTP, you must absent in the capsular vascular invasion. You must absent that one and present of the PTC nuclear chain features. Present actually, not really uncertainty, but we sometimes we put it into uncertainty also. So in that case, we can call it NIFTP. All right. So uh, this entity, this category still they maintain this within WHO book for the endocrine book, but actually it is very helpful for us. Actually, they want to help us because nothing in this world actually, especially during giving diagnosis, sometimes we may have difficulty. Sometimes we might find the uncertainties. Uh, Whenever you have uncertainties, really, really uncertain about it, you can put it in this category. All right. Actually, it is similar to the follicular adenoma and hyperplastic nodule because it is a pure follicular pattern with the surrounding parenchyma, maybe hyperplastic nodules or lymphocytic thyroiditis. Eh? We call it capsular invasion questionable. Why we call it questionable? Because the cells connected with the main tumor nodule invade into, but not completely through the capsules, with or without mushrooming into it. Okay. Vascular invasion is questionable when there is a lack of endothelial covering and isolated thrombus. You want to say it is invasion, but after thorough sampling, you level deeper level, but you still uncertainties, still the uncertainties there, whether you want to call it vascular invasion or not, so that you can put in this category. All right. This is an example of the questionable vascular invasion in well-differentiated tumor of uncertain malignant potential. You can see the irregular outgrowth of neoplastic cells, okay, within the vascular spaces of the tumor capsules. But there's yeah, really no the fibrin formation or the thrombus formation is not happen inside here. Maybe that cause you very in dilemma. All right. So tumor cell closely intermates with the vascular spaces of the tumor capsules. Yes, this still causing you dilemma. So you need to understand, and for the NIFTP also you need to understand when we can diagnose NIFTP, non-invasive follicular thyroid neoplasm with papillary-like nuclear features. Okay, the main idea here, they change carcinoma into the neoplasm. Huh? Previously, many cases we diagnosed encapsulated follicular variant (PTC), but from the study they found that this is very, very non-invasive tumor. This is very good prognosis, just like the follicular adenoma punya character. Many cases have been over treated because we diagnose encapsulated follicular variant PTC. That's why they come out with this NIFTP. The idea is they change carcinoma into the neoplasm. And then another thing, they put the papillary-like nuclear features, although actually this is not papillary-like nuclear features. This is in giving the diagnosis, it is a really PTC nuclear features. But the term we call it papillary-like nuclear features here for the dia punya nama, this term, maybe we don't want to call it, overcall it as a PTC or carcinoma, papillary thyroid carcinoma. All right. So it is must be a solitary tumor with follicular growth pattern and PTC nuclear features. sometimes maybe not reach full criteria. That's why in giving a diagnosis of NIFTP, they come up with the nuclear scoring. Nuclear scoring, 2 to 3, we can call it NIFTP. 2 to 3, not only a 2 or partial criteria only. All right, and not only 2 score only, but 2 or 3 score. Okay. And it is extremely low malignant potential. It's located between the well-differentiated tumor of uncertain malignant potential to encapsulated follicular variant PTC. Okay, and 10 to 20% of all thyroid cancers and typically euthyroid. The history, I think I've mentioned this. The following studies done on encapsulated follicular variant PTC not associated with fatality rate. No fatality rate potentially. And encapsulated follicular variant PTC is indolent and cannot be approached as follicular carcinoma. All right. Um, Papillary formation is something important to find out. Yeah, I did mention just now. Make sure no well-formed papillary formation in NFTP. Okay. Okay, this is another the key histologic features in FTP. It must be complete, usually thin capsule and well demarcated. Okay, absence of invasion, a follicular growth pattern, have a PTC nuclear features score 2 to 3. All right. Okay, and this is the key diagnostic criteria. You must go one by one. All the key diagnostic criteria: encapsulation or clear demarcation, follicular growth pattern must be clear, follicular growth pattern with papillae less than 1%. Papillae here meaning that well-formed papillary formation less than 1%. But here, the latest, not the latest, I found from the, they don't want any papillary formation, not even less than 1%. Because I did mention just now, because of few cases, even they have a very well formed papillary formation, a small area that's actually that causing the metastasis. That actually the conventional PTC. That's why we don't want at least any well formed papillary formation in NIFTP. And no must be no seminal bodies. Okay. If you have another feature, another tumor growth, solid trabeculae or insular must be less than 30%. Yeah? And the nuclear features of papillary, nuclear score 2 to 3, no vascular capsular invasion, no tumor necrosis, no high mitotic activity. If you have the more mitosis, you cannot say in FTP, you need to think of another diagnosis, right? That's why you need to understand really well the key diagnostic criteria to call it NFTP, all right? Okay, this is example of the complete encapsulated, sharply demarcated follicular nodule, the under-scanning view. And then you can see here, okay, maybe you can, when you see the nuclear features, yeah, it's not that full-blown nuclear papillary thyroid nuclear features, especially for the what we call the clearing. It's not that clearing the cell, but the cell looks very the larger increase in the size, and there's an elongation. There's some grooving here and there. All right, this if according to the score that given by the Nikiforov scheme, it's fall under grade 2 nuclear features. Okay, I want to show you what does it mean with the grade 2 nuclear features. Okay, whenever you do the assessment, the nuclear grade assessment score, the things, the features that you should consider: the size and shape, including the enlargement, overlapping, crowding, elongation. This is a one criteria, one score. If if the cells only showing this, the number one is only score 1. It's not yet PTC nuclear features, all right? If they have the membrane irregularities, whether if it's grooving or inclusion, irregular contour, okay? One and 2, so this is score 2, all right? When they have also the glass clearing effect, which is the chromatin character due to chromatin character, this is score 3. You, this image can give you a can guide you. You can compare with the image, the normal thyroid follicles in the insert here. For example, here it's just a big enlargement of the cell as compared to the insert follicular cells here. The enlargement, the crowding. All right. So this is only score one, and when you have this one, which is lack of the clearing, but the cells are enlarged in size, maybe here and there, the growing here and there. So this is score two. This is considered PTC nuclear features, score two. And when you have everything, the elongation of the cell, enlargement, the crowding, and at the same time you have irregular nuclear contour. Now, okay, irregular nuclear contour and the clearing. Yeah. So now this is score three. This is what it means with the scoring. All right, nuclear score. Okay, 2 and 3 we can score 2 or score 3. We can consider that this is the nifty P, or we consider as PTC nuclear features. All right. So this is algorithm, WF algorithm. Yes, I make it this algorithm. You cannot see this in anywhere because this is my algorithm. It looks complicated, but I believe it covers everything. All right. So when you are dealing with well encapsulated or circumscribed follicular tumor of the thyroid, okay, first, you need to see the capsular or vascular invasion or not. Okay. Okay. Well, there is no capsular invasion. So put in your mind, oh, so this might be follicular adenoma or nifty P. All right. But when you see uncertain, not sure whether there's invasion or not. After thorough sampling, still not sure. So, but you need to, there's a meaning inside your head now because there's an uncertain in the vascular invasion. It may be follicular adenoma, maybe that's not invasion. So maybe follicular adenoma or maybe invasion, maybe follicular thyroid carcinoma, or maybe follicular uncertain malignant potential, or maybe nifty P or follicular variant PTC. All right, but if you can see the straightforward, straight cut, this is an invasion. So back in your mind, you need to think of the follicular thyroid carcinoma or follicular variant of PTC. All right. After all, you need to see the nuclear features, the papillary thyroid nuclear features. Okay. This case, there is no capsular invasion. When you examine the morphology, also no PTC nuclear features. So that's it. That is follicular adenoma. All right. But when you see the PTC nuclear features, you found, yes, this is PTC nuclear features that given the score of 2, about 2 or 3. All right. So you can give a diagnosis of nifty P. All right. But when you are not sure about the PTC nuclear features, still you can give a diagnosis. Okay. Go back to the nuclear scoring just now. Go back to the nuclear scoring just now. Careful, examine carefully, look at the nuclear features carefully here and there, whether which score it is, whether it is considered a 1 or 2 or 3. If you think that this is a 2 or 3, you can call it nifty P, all right? But after careful examination of that nuclear features, so you think, no, this is not a papillary nuclear features. So call it follicular adenoma, all right? So settle for this one. How about this one? There is uncertainty in the capsular invasion, but after you examine, thank you, after you examine the PTC nuclear features, and you say, oh no, this is no PTC nuclear features. So, but you are uncertain about the capsular invasion that fall under criteria of the follicular tumor of uncertain malignant potential. You need to mention in your report when you give this diagnosis, the what we call, saya punya ni nampak tak? Highlighter, laser pointer. Nampak? Okay. Laser pointer. Okay, when you give a diagnosis of follicular uncertain malignant potential follicular tumor, you need to give a comment because they sometimes blur. They don't like, of course, clinicians, surgeons don't like something that uncertain. They like something certain from us. Huh? The things that they don't want is something uncertainty from us, because they see us someone that can give a very good diagnosis. That's it, the real certain diagnosis. They don't like this diagnosis. That's why you need to mention why we put this category. And this category fall under in between which category we are thinking what. So we need to mention that this lesion standing where it is actually in between the follicular adenoma to, and follicular thyroid carcinoma. We put it follicular tumor of uncertain malignant potential. Because why? Because we are not certain about the capsular invasion. All right? Make them clear about that before we put this category as our diagnosis. You not remember, you cannot assume that they know everything, all the entity that given in the WHO, right? Okay? Do not assume that. Okay. But when you have the uncertain in capsular invasion, but also uncertain in the PTC nuclear features, still not uncertain as well. You can call it wild differentiated tumor of uncertain malignant potential. But in your report, you need to mention this entity is actually in between the nifty P and follicular variant PTC. However, we are not certain about the nuclear features and as well as the capsular invasion. All right, so that everything become clear. Oh, the pathologist thinking of that, but they are not certain about that. They put the diagnosis that, right? I hope everyone clear. Okay, but if you're not certain about the capsular invasion, but you are certain in terms of the nuclear features, all right? So at least from the nuclear features, at least this is nifty P. But you still cannot exclude, you need to mention in the report, you cannot exclude the follicular variant PTC because you are not certain about the capsular invasion. All right? Understand? At least you're confirmed that this is nifty P. Right. Okay. Now we go to the last algorithm. Okay. When you have the capsular invasion, confirm capsular invasion. Okay. So in your mind, whether follicular thyroid carcinoma or follicular variant PTC. But after careful search of the nuclear features, you found it no PTC nuclear features. So that's it. This is a follicular thyroid carcinoma. Okay, but when you found it, yes, it full of PTC nuclear features. So this is the follicular variant PTC. What I mean the follicular variant PTC here is referred to the encapsulated follicular variant PTC with invasion, because we are certain about the capsular invasion just now. All right. But when you see under microscope the nuclear features, you are still uncertain about the nuclear features. Okay, but bear in mind you are dealing with a well-differentiated carcinoma. Why? Because you are certain about the invasion. Okay, capsular invasion. You are certain now, but only not certain in terms of the PTC nuclear features. This is a carcinoma. Okay, only that you are not sure whether this is PTC nuclear features or not. I advise you to go again to the nuclear score. Read carefully, examine carefully the nuclear features, whether the scoring 0 to 1 or 2 to 3. If you, after thorough examine, you say, no, this is not nuclear feature, PTC nuclear features. So happily call it follicular thyroid carcinoma. All right? If you found it, yes, I think this is maybe not well developed, but maybe score two. Score two, you from your score. Yes, so this is a follicular variant PTC. All right. I hope everyone happy with this algorithm. I hope I not make everyone become more confused. Okay, you can refer this WF algorithm if you have problem or dilemma in diagnosis. All right. Okay. Okay. Now we go to the case examples. Any questions so far? I cannot see the chatting or here. Any, okay. So
Okay,
if no,
Dr. Wan.
yeah, all right.
Nak jawab ke or we go until at the end baru kita jawab?
Ada soalan ke? Saya tak nampak.
Ada soalan.
Okay, boleh tanya tak satu dua soalan dulu sebelum kita pergi example of the cases.
Okay, sekejap ya. Saya
Yeah.
bacakan. Sorry. Good morning, Dr. Wan. This is from the. I need to open it. Okay. Good morning, Dr. Wan. This is from Eng. Want to clarify regarding the assessment of TTC nuclear score. Is neoplastic cells only show enlarged nuclei with chromatin clearing without significant irregular nuclear membrane or inclusion or grooving? Can this be score 2 TTC nuclear features?
If you are really, and thank you for that question. If you are really convincing with the clearing just now and the cells showing the enlargement of the cells as compared to normal thyroid follicular cells, and about the clearing is very convincing. Actually, kalau according to this score, it now become score 2. It's only have lacking in terms of grooving and inclusion. I advise for you to really search for the grooving, especially for the irregularity of the contour. Okay, because that is actually personally I like to have the number 2, at least one of it, the membrane irregularities, whether irregularity of the contour, the grooving or inclusion, either one to say it. But if really the clearing is very marked for you, you are very sure about the clearing and the cell, the enlargement, the overlapping, everything. This kalau according to this score, it now become a score 2 because at least 2 score kan. So I advise to search again. If you think not that the clearing not that confident with that clearing, you can go up to become a score 1. So okay, make sure your clearing. Make sure the clearing is really the nuclear clearing due to chromatin. Apa tu? Not like the the clearing because only the at the central only. Sometimes it may have clearing, but only at the central clearing. But you can still see the uh, apa tu chromatin, a lot of chromatin outside. But clear, make sure there's a really glassy punya clearing lah. Alright.
Oh, okay.
This is still dilemma, I think, for the nuclear chlorine because it still inter-observer variation, right? But yeah, difficult to unless rasa nak tengok je kan apa maksud dia clearing tu. Susah nak explain. Alright.
Okay. In regards to the same question, I think we can take one more question. This is
Okay.
regard for the nuclear feature as well lah. Morni from Dr. Morni. In NIF-TP, should the PTC nuclear features be diffuse or can only be focal? If it's focal, what is the cut-off percentage?
Oh, so far no percentage given for this, but it mentioned that that features, the nuclear features, not necessarily confined to the large area to that, but it can be scattered here and there. Kalau focal, I assume focal mean maybe one single focal macam tu kan. Kalau dia tak ada pula explain macam tu. Kalau on that features is just a really very focal, very small area, saya tak consider lah. Tambah-tambah pula dia only the score 2 ke top up to score 3, saya tak consider lah. Sebab dia tak ada pula mention focal pun dikira, tapi it can be scattered here and there. Here and there. It tak semestinya the whole area like that. It can be scattered. Okay. Kalau focal, I don't know how focal is focal. Kalau focal sikit sangat, maybe we cannot consider lah. Okay. Kalau focal here, yes. That's my opinion. Maybe another person have another opinion. Sorry for that. Okay, can we proceed with the case examples?
I
All
think
right.
yes. And we'll start one more question to the last because panjang sikit question
All
tu.
right. Okay. Ah. Oh, okay. Last. Oh,
Okay.
okay.
Tak. Boleh sambung, continue.
Boleh sambung.
That question we save it to the last because panjang.
All right. Okay. All right. Okay. We get to the case number one. Just sharing je ni. Case sharing simple-simple sahaja. Okay. The case 36-year-old Malay lady with midline swelling for 7 years, progressively increasing in size, euthyroid, normal thyroid function, euthyroid, and right hemithyroidectomy done. The ultrasound shows TRX5, the ultrasound Thigh 3, the FNAC Thigh 3. Okay, gross encapsulated lesion. Okay, reason of referral, query edematous nodule, query well-differentiated tumor, uncertain and potential, query invasive encapsulated follicular variant PTC. This is all our dilemma that suit to our topic today lah. Alright, so that's why I bring up this case. Okay. Okay, so what we have is a well-encapsulated tumor with moderately thick capsule here, okay, with the tumor is composed of predominantly micro follicles with scattered maybe normal follicles, all right? So, yeah, I need to change this one because when we use this one, there's a pointer tadi, pen, arrow, okay. Dia susah nak gerak slide ni. Okay.
Oh.
Um, when you can see it's still well encapsulated tumor here. What we have in the tumor shows in some areas the tumor shows these features. Okay, we have follicles with a colloid inside, and most of the colloid is very deep eosinophilic bubble gum colloid inside there. All right. Okay. Even under this power, we can still see the very deep eosinophilic, very macam nampak macam bubble gum, dia macam colloid. Okay. This is what I mean. The bubble gum colloid inside the follicles, and then associated with the peripheral scalloping. You can see the peripheral scalloping of the colloid, okay? And then you can see here and there the nuclear features, maybe not, the clearing is not that marked but the cells have a occasional pseudo inclusion I found in this case with the enlargement of the nuclei, with some irregularities of the nuclear contour. You can see here, there's some grooving here and there. The clearing only scattered, not that many, but the important rather than clearing is the enlargement of the cell, the elongation of the cells. Okay, irregular contour of the cells, that's very important. And then the growing here and there. Sometimes you not see pseudo inclusion, no problem, but you can see the growing here and there. So this is the PTC nuclear features. Okay, so when I have PTC nuclear features like this, well encapsulated tumor, well encapsulated tumor, so I need to, at least in my mind, oh, I'm dealing with NIFTP, all right, NIFTP, because there's a PTC nuclear features. I convinced with what I see, I convinced this is a PTC nuclear features, all right, with the extra features lain like bubble gum colloid, dense eosinophilic colloid with the substantial fibrosis here and there. That the features too to help you toward the nifty P and the follicular variant PTC. You kena tengok juga selain pada nuclear features tadi, untuk penanya tadi who asked me about nuclear features. If you in your mind you are thinking of nifty P or follicular variant PTC, you need to see another features, especially the peripheral scalloping of the colloid, dense colloid, follicles, irregular follicles, not very fine, very good follicles. The follicles look very irregular here and there. elongated follicles that contain colloid, pekat colloid to dense colloid. Kena tengok juga tu. Okay, other than the nuclear features, right? So in this case, I convinced that this is a PTC nuclear features. Only that I'm not sure about the capsule, so need to search for the capsules. Kalau no capsular invasion, at least in my mind, nifty P, right? So, but in this case, I searching around, and see dia punya apa tu capsule. Yes, I found there's a capsular invasion actually in this case. Okay, this is after levels. Okay, after level we found it. This is a invasion. Maybe apa tu the one who refers say another nodule, but actually not another nodule. This is the original capsule of the tumor, and this is the focus of the invasion of the tumor. Okay, you can see the tumor invade. Okay, so when I have this, when I have this, so I can upgrade into the encapsulated follicular variant. Okay, PTC. I want to show you another cases. This is a fresh case I just reported out this on Thursday this week. Okay, 46 years old lady, post total hemithyroidectomy, the left thyroid with encapsulated follicular pattern tumor with questionable capsular invasion and partially developed PTC nuclear features. Okay, this is what um, the one who refer to us as plain because they are very questionable on the capsular invasion and partially developed PTC nuclear features because they are not convinced that this is a PTC nuclear features. If you have this case, you need to ask people who maybe know about that, discuss what does it mean. Maybe for you, you say partially developed, but maybe some other people, they say well developed, not partially developed. That's the same thing with the questionable capsular invasion. Some people say this is questionable. I don't know, not sure. But when other people see it, yes, this is capsular invasion. Okay, something like that. So this case refer because of that. The reason of referral, not sure whether maybe this case fall under the uncertain malignant potential. Right. So sorry, I'm not taking a proper picture for this case. I tried the new camera that the Olympus bagi pinjam. So I try guna phone sahaja. I lupa nak snap dia punya capsule. This is actually the well encapsulated tumor with moderately thick the capsules, not include in this picture. Okay. And you can see the tumor is composed of follicular growth pattern, mostly follicular growth pattern, but the follicles not very well follicle, macam comel follicle, but it is some follicles very look elongated, irregular follicles, okay, that contain colloid inside the follicles. But I think some of you will agree with me. Even under this power, you can see something wrong with the nuclear features, right? Okay, we go under higher power. Okay, you can see in many areas it shows these features. Nah, you know this is a bubble gum colloid with peripheral scalloping here and there. Okay, this is a good clue for you to think about nifty P or follicular variant PTC. Okay. Okay, this is one of the features that guide me to give a diagnosis. And look at the nuclear features. Although there is not mark maybe in this area lah, ada clearing tapi maybe not mark. This is a nuclear clearing in another area lagi banyak lah. Okay, I give the score of the nuclear scoring is 3 in this case. It has an elongation, enlargement of the nuclei, overlapping elongation of the nuclei with a clearing, grooving ada, cuma satu je tak ada, inclusion tak ada, but still can call it nuclear score 3. Semua all the criteria, 3 criteria tadi semua ada. Alright. So this case PTC nuclear features, I have no doubt. I have no doubt in this case. This is a PTC nuclear features, but only the doubt is in the capsular invasion. Okay. So in many areas I found this. Okay, this is a capsular invasion. If you can see, there's a reaction towards the cells here. This is the capsules. This is blood vessels. Okay, not convinced with this one. Okay, Go another area. Okay, this is another area. Yeah, I think this is a capsular invasion. You can see the tumor invade the capsules here and there. Some of it going into the vessels. All right. Okay, maybe you're not convinced with this one. Okay, what you should do? You need to see the surrounding, the outside of the nodule. Okay, I'm searching the outside of the nodule. You see what I found? There are only there are many satellite nodules. There are many focus of this kind of tumor going outside of the nodules. So no need to think very hard about the invasion anymore because actually it's already invade outside of the nodule. You can see this is a tumor cell that going outside of the nodules now. Okay, again, this is a big a large focus of the tumor cells that going outside. This is the capsules, and this is the tumor cells, satellite nodules. And I found another tumor cell outside of the nodule. Okay, this is the tumor cells outside of the nodules. So in this case, there's no doubt for this case to have the capsular invasion. There's no doubt in this case to have PTC nuclear features. So come on, you can give a very convincing diagnosis now, which is another features. I found that near the capsule there's a abortive papillae. Okay, abortive papillae is a sometimes it's very helpful for you to give the diagnosis of follicular variant PTC. That it give a clue that you are dealing with the papillary thyroid carcinoma, which is follicular variant. But if you found a well-formed papillae with a very well, what we call the very fibrovascular core, you cannot say that. Okay, abortive papillae, yes, right. So this case, actually this case is similar to the previous case. Case 1 and case 2, the same diagnosis. This is an encapsulated follicular variant papillary thyroid carcinoma with invasion. All right. No, because it has a capsular invasion and it has the follicular variant. No, it has a PTC nuclear features. Score 3. All right. So both case 1 and case 2, it is a solitary thyroid nodule, which well encapsulated nodule, having the microfollicles with deeply eosinophilic bubble gum colloid and peripheral scalloping. PTC nuclear features of score 3 with capsular invasion. All right. So why I didn't call this well-differentiated tumor of uncertain malignant potential? Yes, I don't want to call this because now I convinced in terms of the capsular invasion and I convinced in terms of the PTC nuclear features. All right. So why it is not nifty P? No, I don't want to call it nifty P because I convinced the capsular invasion. It's not nifty P anymore. All right. So I hope everyone clear about this case. All right. Okay, so the diagnosis is encapsulated follicular variant PTC with invasion. Okay, so case number 3, 57 Chinese male with right neck swelling, not increasing in size. His euthyroid, FNAC atypical cells, suspicious PTC, grass left hemithyroidectomy with solitary thyroid nodule of solid cut surface. The reason of referral, he want to call it nifty P, but of course this is a new entity. They're not sure. Is it really nifty P? This is a this case is quite long ago, not recently case, not recent case. Mm. So what I have is a tumor, well demarcated, a complete thin encapsulated nodule with the thyroid adjacent known to minimally compressed only by the tumor. And it has a closely packed microfollicles inside here. Okay. Remember to look at outside the nodules, the surrounding thyroid parenchyma. What are they doing? Are they showing the nodular hyperplasia features, or are they showing the lymphocytic thyroiditis, something like that? Okay, usually two of them are quite common to have the. Okay, from this I found that this the surrounding thyroid showing the vague nodularity. Maybe it looks like nodular hyperplasia of the background, all right? Vague nodularity. All right. So what about the tumor? It composed of this kind of nuclear morphology. If you can see from this power, is forming of follicles with contain colloid inside there, all right? And the cells are overlapping, elongation of the cell, nampak oval in shape of the cells with the grooving here and there. Some of the cells are irregular nuclear contour there, okay? Only it's not that marked in clearing, right? So from this nuclear score, I give a score 2. This is not this area only, but several areas. We cannot, I think we cannot judge on one single area. You need to have more than several areas. That maybe this will answer the question just now. Only focal. I think focal that she meant is a one focus like that. This we need to see in many areas, right? Um, yeah, can see again here in another areas. Look at the cell, panjang kan, and look, oval in shape with the grooving here and there, irregular contour. Yeah, still maybe I put it score 2 because not that marked in clearing kan, in this case. Okay, so, so okay, remember that the capsule is complete, no capsular invasion after thorough sampling, absence or invasion. The cells in follicular growth pattern, the PTC nuclear features 2 out of 3, no solid trabecular insular growth pattern. So I just agree with the question, the query. Yes, this is NIFTY-P that suit with the NIFTY-P non-invasive follicular thyroid neoplasm with papillary-like nuclear features in the background of nodular hyperplasia. Why I like to see the background? Because I want, because in my mind, I'm thinking also the follicular adenoma. If there is no background of the follicular, the nodular hyperplasia, so my consideration also follicular adenoma. All right. But with the well-formed PTC nuclear features, now I call it NIST-P. But I put in the comment there, this entity was formerly known as non-invasive encapsulated follicular variant of PTC, but with more favorable prognosis and very low malignant potential. The differential diagnosis in this case is edematous nodule in the background of nodular hyperplasia. In view of the presence of 2 out of 3 PTC nuclear features with well-demarcated thin encapsulated nodule in 57-year-old gentleman, lelaki, risau terot ni lelaki, NIFTY-P is the most likely. However, this newly described thyroid tumor has good prognosis with extremely low recurrence rate, less than 1%. All right, we need to give a comment like this because we need to educate the surgeon. Okay, this is a new entity. They don't know what really NIFTY-P is. All right, so that's our responsible to educate them by giving the such comment to them. All right. All right. This is the last case. The last case for today. For today's sharing, we have a 29 years old, still young. Okay. When it is young, we because I like to see the age because according to age, there's some differential in my mind actually. Okay, 29, Malay female, neck swelling, 1 year, presented with dysphagia and hyperthyroidism. This is a good clue. Patient hyperthyroidism. Okay, it's quite like this. If hyperthyroidism, we are thinking of something not cancer, like that. Okay, gross total thyroidectomy. A well circumscribed lesion, the whole left thyroid lobe with another nodule found adjacent, the right thyroid nodular lesion. Reason of referral, the referral thinking of NIFTY-P. Just want to confirm with me whether NIFTY-P or not. Okay, so what I have here is a well encapsulated tumor, distinct nodule which with moderately thick capsule. Moderately thick compressing the surrounding follicles. When it compress the surrounding follicles like this is a good clue for you. Usually the one who compress meaning that there's a lesion which is very apa tu cepat lah dia lebih kepada clonality punya lesion lah, neoplasm punya lesion kalau really compress the surrounding stroma rather than the hyperplastic lesion like adenomatous nodule. It's not really compress the surrounding, but the clonality, the neoplastic punya lesion dia akan expand and expand, compress the surrounding thyroid follicles. All right. And what we have, the patient have a solid, this area is showing solid trabecular macrofollicles, normal follicles, okay? Meaning that the mixed pattern of growth. It looks at micro or solid here and normal follicles here, right? And looking at the tumor, within the tumor, what we found, it forming a follicular growth pattern with cells with clear cytoplasm. The follicular cells have clear cytoplasm. Under this power, you found it, oh, it's clearing. You think of the nuclear clearing, but that's not nuclear who are clearing here, but it is a cytoplasm clearing. And the follicles having a bubbly, pale, watery colloid with peripheral scalloping. Okay, it peripheral scalloping, but the colloid is very pale, thin, different from the follicular variant PTC just now or NIFTP with dense eosinophilic colloid. But here you can see it's very pale, bubbly, the colloid here. Okay, and the cells, okay, look at the cell here. This is not nuclear clearing, but cytoplasm clearing. Okay, but it gives a clear effect. The cytoplasm punya effect tu. And at the same time they have the scalloping tu. Scalloping, bubbly punya, watery like bubbly colloid. Okay, but there is no PTC nuclear features. No PTC nuclear features because you can see the follicular cell very rounded, cantik macam gula-gula. Okay, rounded punya follicular cells. Oh, rounded, comel. Okay. Look at here, under low power macam ni, you nampak this is a solid area. Solid area, but still you can see some of the follicles nampak forming a peripheral scalloping. Okay, nampak ada colloid, bubbly colloid inside there, here and there. But the one that clearing is the cytoplasm, not the nuclear. Nampak nuclear ni comel, bulat-bulat-bulat, pale, apa ni? Nuclear, apa panggil, bland looking nuclear lah. Okay, solid and macrofollicular patterns. Look at here, this area. Okay, the nuclear rounded nuclei. Okay, but the one is clearing is the cytoplasm with this apa ni, scalloping here and there. So the diagnosis in this case is presented with hyperthyroidism, a distinct nodule with complete moderately thick capsule. It composed of solid microfollicles and normal follicles. The cells cuboidal, columnar with basal nuclei having clear vacuolated cytoplasm. The colloid is pale and watery with peripheral scalloping. Okay, so this is actually the follicular adenoma. But it is a special type of adenoma. We call it hyperfunctioning or toxic adenoma that tally with the clinical findings. Okay, so whenever you are dealing with the adenoma, this is what we call special about adenoma. They are composed of their special cells inside. For example, in this case, all that this is cells with showing the top hyperfunctioning cells. But sometimes you have cells like I recently received another case from the HSNZ as well last week because I conclude that also the follicular adenoma it composed of clear cell, long clear cell. Sometimes if you see the cell, it looks like the parathyroid cells, very nice cells. That's the character of the adenoma because it is a neoplastic and neoplastic. They like a clonality. They compose of this a similar type of cells, and the cells not like nodule hyperplasia punya cells. The cells ada karakter dia sendiri. Whether it's clear cell change, ada the cytoplasm, like clearing of the cytoplasm. Macam tu lah. In fact, ada what we call the signet ring cells. Dia ada typical features of the cells. Okay. I hope by that it's very this session I hope is very helpful. Can help you in giving diagnosis, especially when you are dealing with a dilemma cases, or especially for the follicular thyroid lesion. All right, that's all from me. I think I want to pass to Dr. Zara.
Dr. Wan, can you hear me?
Yes. Boleh dengar. Okay.
Right. Okay. At the moment we have just now the long question yang belum jawab lagi. We have one. So anybody who wants to ask question, feel free to type into the chat box. The question is from Dr. Rahima. Fletcher mentioned that minimally invasive follicular carcinoma in bracket with capsule invasion but without angio invasion has approximately 0% distant match. Have you came across any cases where by initial hemithyroidectomy diagnosed as such but later surgeon proceed with completion thyroidectomy and the specimen shows a well encapsulated nodule with adenomatous features with no capsular invasion nor angio invasion? What will you call the second specimen? Max follicular carcinoma, follicular adenoma, or adenomatous nodule? Dr. Wan, you get the question?
Maknanya yang first diagnosis tu meaning that it give a diagnosis of the minimally invasive follicular carcinoma. That one is not the total thyroidectomy. Maybe that one is from the maybe the left lobectomy lobectomy macam mana nak lobectomy macam mana nak diagnose, maybe tak complete kan. Let's say the first one is the left thyroidectomy lah kan, and then the second one they doing the completion thyroidectomy. The first one is considered complete, meaning that it remove the one of the thyroid lobe, which is the right thyroid, and you found it, this is a capsular invasion, and you are very convincing that this is capsular invasion. That's why you come out with diagnosis of minimally invasive follicular carcinoma, right? But only after the completion is you don't have the invasion. So maybe just that's it. You have diagnosed the follicular, the minimally invasive follicular carcinoma from that lobe. Okay, so the completion lobe you don't have that. That's a normal to do for you to don't have another. I mean the completion one is not follicular carcinoma. Kan, maybe the completion one, this is the background of the follicular nodular hyperplasia, adenomatous nodule, right? That's what I understand from this case. I don't know whether the first one is what actually. Is it the right thyroidectomy? Usually we give they give they remove the thyroid, maybe the right thyroid, left thyroid, or maybe in this case just lobectomy. I don't know. I'm not sure. But
sorry, Dr. Wan, Dr. Rahima here. So the first specimen is a hemithyroidectomy specimen, and with that, yes, hemithyroidectomy specimen, and there is a well encapsulated nodule with presence of capsular invasion. So it is signed out as follicular carcinoma, minimally invasive. But then somehow the surgeon proceeded with total completion thyroidectomy. So we get the remaining thyroid lobe. And in this particular specimen, again, there's another well encapsulated nodule, but there is no capsular invasion, no angioinvasion. So in this case, what will you call it? Is it metastatic follicular CA or follicular adenoma, or in case if there's no compression to the surrounding of the thyroid parenchyma, so can it be just adenomatous hyperplasia?
Oh, okay, Dr. Rahima. Thank you for that. It's a very good question. It's very good. I think it causing me a dilemma, because meaning that in this case, in this case, patient have multiple nodules, right? Meaning that one nodule have been removed from the hemithyroidectomy, and then another nodule, from the completion got another nodule, not the similar nodule from the one from hemithyroidectomy, right? This is another nodule. And then I want to know the background, the surrounding. Is it showing the hyperplastic nodule, meaning that had nodule hyperplasia surrounding?
Fairly normal.
Normal.
No compression of it's just that's one nice well encapsulated nodule seen within the thyroid parenchyma.
So in this case, you have two nodule, right? Two nodule. Because
one in each lobe lah, because the first one is in the left and then this is in the right.
Oh, okay. All right. Okay. As you know that, follicular carcinoma just similar to the follicular adenoma. That one usually is solitary single nodule. All right. If you are confident that the first one is the capsular invasion, I think you no problem with that. You can proceed with the minimally invasive follicular carcinoma. And if from the completion you have the same lesion from the first one, maybe that one is maybe there's a that one is capsular invasion, right? So maybe dia boleh another boleh can have another nodule for that, but that one is completely no invasion, right? No invasion, that one. Yeah, you can see whether if there is no features of hyperplastic nodule or whatever, you can still see that, you can still call it follicular adenoma in this case. Yeah, that what I want, that what I think I can give lah. We cannot say for the second this is follicular carcinoma as well, because it's well encapsulated, right? Well encapsulated tumor without any invasion. So we cannot call this the follicular carcinoma for the second nodule. For the first one, if you're convinced that that is capsular invasion, so no problem, you can proceed with that without any amendment. You no need to do any amendment for that. All right. So sorry for that answer, because that's from what I understand and from my opinion. Maybe in other expert would like to offer their answer. That's I really appreciate it. All right, thank you, Dr. Rahima, because it's quite difficult in this case. But as long as you see the first one is the capsular invasion, so that's it. Is it not? Muha? How are you, Muha?
Okay lah, saya share sikit lah.
Okay, share.
Kalau saya jumpa the right one is tadi Dr. Rahimah cakap the right one is cakap right lah kan, senang sikit. Yang sebelah kanan tu is
yang remove tu lah, yang dah remove.
The first one is minimally invasive. So when minimally invasive couldn't be any metastatic at all, isn't it?
Yes.
Yes, basically. So you don't see any lymphovascular invasion. And suddenly, bila surgeon remove another site, then jumpa nodule. So the first thing yang saya akan buat is saya akan compare both nodule. Is it the cell is the same? Because if it's follicular carcinoma, usually dia punya pleomorphism of the cell marked sikit berbanding dengan follicular adenoma. So itu yang saya buat, saya comparekan. And is it through capsule on the other side? Ada capsule betul-betul ke? It just push the surrounding tissue. Tapi tadi Dr. Rahimah cakap tak push kan. So kalau saya tengok kalau atypia of the other side of cell is almost the same. So I think this is the match. So I have to go back to the previous hemithyroidectomy, and then saya akan cari juga possible is you miss lymphovascular invasion. And then if you see you jumpa and then you can make diagnosis of metastatic, or you can make diagnosis of, kalau dekat UK hari tu dia pernah buat is a multifocal follicular multifocal carcinoma. Kalau both of cell have the same features lah, atypia of the cells, it's a carcinoma. You're confident that the other side also carcinoma because dia akan ada the same features of the cells tu. Kalau adenoma dia biasanya a bit of mild in terms of it's not neoplastic, true neoplastic kan, macam not neoplastic. So this is another features where is a macam apa dah intra-observer, itulah, it's very difficult actually thyroid. You know, sometimes if you have kids like this, you must, I think it's better for you to send for second opinion lah. It's actually it's okay. Hantar saya okay. Sebab bagi saya, if you have carcinoma, I mean, even it's minimally invasive carcinoma, it's already carcinoma. It can mix, isn't it? It's just like prognosis much slightly better, minimally invasive carcinoma, and then slightly better in between minimally invasive carcinoma or widely invasive follicular carcinoma. It's just that. So even if minimally invasive carcinoma, it can match also.
Yeah,
Kan?
actually,
You dah
yes.
confident dah carcinoma, ada
Yes.
carcinoma. So it's just like the name also. Okay.
Because basically sebab I'm taking the what the Fletcher mentioned lah, sebab bila minimally invasive tu kan up to approximately 0%. Even he himself mentioned approximately lah. It's not like definitive percent, but it seems that it is rare lah kan to diagnose metastatic follicular CA in a minimally invasive follicular thyroid CA, which has only capsular invasion but without the angle invasion. That's why I query lah.
Usually I'll go back to that specimen lah. I'll try to search for possible you miss the vascular. Usually vascular invasion tu yang you selalu usually ada tu biasanya.
Kalau
dah cari, mungkin dia tara sampling lagi lah, sampling lagi
itu
cari
biasanya
lagi.
Vascular invasion tu memang sangat susah you cari. Sometimes dia cakap vascular invasion cannot see, you have to see vascular invasion outside the nodule kan, or within the capsule, not inside the nodule. But you can sometimes you can see vascular invasion in the nodule actually, kan? But the definition dia cakap mesti outside or within the capsule.
Yes. Alright, thank you Dr. Rahimah.
Thank you Dr. Wan, thank you Dr. Moha.
Okay, Zara.
Any more questions? Anybody? Just waiting for kalau orang lain nak ask some more questions. I know this is kind of soalan, not sure. Soalan simple aja. Just nak clarify. The abortive papilla, is it same as pseudo papilla, Dr. Wan?
Okay, pseudo, abortive is dia nak jadi papillary but it's not well formed because of no fibrovascular core. I think yes, it can in terms of that, because both are no fibrovascular core. Pseudo papillae is also, we can consider abortive papillae. As long as there is no fibrovascular core and not well-formed papillary formation. Yes. Prof, Prof nak
cakap, I think.
Prof ada nak cakap ke?
Ya, nak cakap.
Hello, dengar.
Can you hear me? Okay. First of all, congratulations, Dr. Wan. Very good. I'm very impressed, and actually, I'm entering this program for the first time. I'm very happy with what is going on, and I'm very proud that my ex-students are doing very well, you know, in progressing in pathology. I'm very, very happy. So keep it up. And I hope, more people will come up and share their experience like what you're doing right now. Very good. Okay, keep it up.
Thank you, Prof. Thank you so much. My seafood.
All right. Yeah. Bye.
Okay. Just like we don't have any more questions at the moment. Even in the FD pun, we don't have any more I mean, we don't get any more questions. All right. Just a short announcement to everybody. I'm proud to announce that this is we have acquired our very own Zoom platform, and this is our third session. We have started since June with Datin Nick with the GI talk. So following that, I would like to announce that in the coming next year, the Iapmd will impose very minimal, don't worry, very minimal amount of processing fees starting next year. We're still in planning phase. We're gonna get you more great speakers and more established in terms of administration and certification. So with this processing fees, it is thought that it will help in supporting our Zoom subscription, as well as, you know, since I mean throughout these few months, not few, some months already, we have very great speakers, and you know, we really appreciate, you know, all their hard work for giving up their times and knowledge, you know, to just stay and, you know, have this chillax conversation or impart their knowledge. So we hope we can give you know, some sort of token appreciation with on top of the subscription for this upcoming next year with the processing fees. So further details will be laid out inside the website, so just stay tuned for that. And I would like to also announce that next month, that will be September, we have another great talk on CNS by our very own Dr. Haizura. He just recently came back from her sub, so please join for next month IAP Weekend Live. Dr. Wan, you have anything more?
Dr. Zara, kita ambil gambar sebelum orang lain leave.
Nak cakap je.
Okay.
Zara,
yes,
can you remind people to attend the AGM in October?
Yes.
Okay, and hopefully all members are joining in, because it's going to be virtual, so it'll be easy for everyone to join in. And if they are not members yet, you please sign up to be members, and hopefully live members, so easier for us to, you know, organize membership. All right? Okay, go on. Sorry, take our photos.
Yes, and I think all the members yang dah dapat emails, please send in your vote. We will try to help Dr. Ifat and settling on because this is our voting year, right, Prof?
Yes.
So please send in your votes as
well. Yes, it's our voting year, and ask them please to go nominate members that they like to be on board.
Yes, Prof. You are live now. You can continue, Prof.
Yes, continue.
All right. I think Dr. Wan, you have anything else to?
Just nak ambil gambar.
Okay.
Lepas tu tadi I terbaca satu komen orang kata maybe boleh free untuk live member untuk fee untuk ni lah weekend Iapmd. Tapi tak apa, kita akan bincang benda tu nanti. Right.
Yes,
boleh kita ambil gambar ke sekejap buat kenangan?
Zara dah buat.
Siapa yang available, you can on your video. Saya nak ambil gambar sekejap.
Okay, Dr. Wan. Saya tak pandai sangat guna dengan
saya boleh snap.
Window. Kalau Apple senang sikit, Mac.
Siapa yang available, can you please turn on your video so that I sebenarnya nak tengok muka juga. Lama kan kita tak face to face, lama sangat dah. So kat sini lah boleh tengok.
Okay. Boleh buka video everybody. Prof, Dr. Salina, siapa lagi?
Hai Faiziah. Faiziah kat Sabah ke tu?
Dr. Yatiza.
Ada yang refer case tapi saya tak pernah pun nampak. Tak kenal pun sebenarnya. Kalau buka on video saya boleh kenal. Tengku Nordiana nampak muka, nampak gambar sahaja. Tak ada video. Su Anida ada? Su Anida.
Suen. Tak.
Suen.
Saya panggil
Okay,
Suen.
Prof duk berjalan. Alright, saya ambil lah mana ada video ni. Okay. 1, 2, 3. 1, 2, 3. Okay, thank you Zara for very good, I think, session chat by you. I think actually we doing once per month, monthly. Zara?
Yes. We do at the moment once a month, monthly lah.
Okay. Next year jangan lupa masuk Muha pula next year.
Itulah.
Tahun ni nampak macam dah penuh tu. Kalau ada slot lagi, tak Muha pula. Tu Muha. Dan macam mana kita minta lah penyertaan ramai lagi yang nak sharing kan. Kita boleh dapat ni.
Itulah kalau
Wan,
tukar-tukar MC sekali pun.
Wan, macam endocrine ni dah banyak sangat lah. 3 kali dah. Wan 2 kali. Dah tahun ni dah banyak kali. So saya rasa nak dengar Dr. Suhaila Abdullah pula.
Suhaila Abdullah ni apa dia? Bukan endocrine lah. Benda lain kan.
Ella lah.
Euro. Yalah. Euro. Ada dalam jadual ke Euro?
Tahun depan memang dah nak tahun depan.
Tahun depan. Jangan lupa masukkan semua. Alright. Okay.
Euro system maksudnya rasa base better system by system lah kot sebab dia many system.
Betul lah sebab itu pun ni dia orang letak ni sistem lah ni thyroid gitu. Kebetulan kita baru lepas seminar thyroid dulu.
The first tu one buat breast kan.
Breast.
Recipe possibly tak ada lagi. Dr. Adam. Saya nak dengar Dr. Suara Adam. Mas Adam.
I think Dr. Moha, you may need to request. Saya dah request dah. Dia dah reject saya. So Dr. Moha dah try request kat Dr. Adam.
Oh iya ke?
Dia reject dah.
Renal pun boleh juga. Renal pun belum ada kan?
Renal belum lagi ya?
Belum.
Renal ada. Baru bulan lepas. Dr. Kota,
EM lah, tapi is that one EM is not morphology
yang
lah.
Yang diagnostik belum lagi lah. Maybe later on kita ada banyak juga orang renal kan. Renal.
Yes, renal. Cytology dah selalu sangat. Betul tak?
Head and neck pun tak ada lagi saya rasa.
Ya, Dr. siapa? Dr. kat Johor.
Dr. Ya Allah, tiba-tiba lupa.
Dr. Aida.
Dr. Nuraida, yes.
Nuraida, yes. Okay.
Alright.
Anyway, just kalau siapa-siapa ada idea or interesting topic, just email to your IAP Gmail tu, and then we can get done lah hopefully. So towards the end ni we have lagi 2 more part after CNS would be molecular and satu lagi lympho-reticular. So we wait for Dr. Faiz dengan Dr. Nohayati Omar. Alright, thank you everybody. So
thank you very much everybody.
Yes, okay, see you.
Alright, bye. Terima kasih Moha.
Okay.
Terima kasih Zara. Thank you.
Terima kasih Dr. Moha, Dr. Wan. Everybody, terima kasih.
Terima kasih semua.